Mark, I can actually relate to a few of the stories that you've said. You said just last week we did actually 3 by 1, which is starting a transplant at 4 a.m. just so we can get that to our cases. And I tag team with Mike Tong, and we did the transplant 4-3 to heart and liver transplant that we've done in the morning, and then we did our 2 elective cases, and we were done by 1. So that's an incredible team that can flex when it's needed. So I'll share with you the results of the congenital surgery. We continue to increase our volume. What we're proud of is really the results of this. This is a contribution between the adult congenital. There's a lot of material growth in the adult congenital as well as the pediatric congenital. It's a very competitive field where we are geographically, but what we're proud of is the outcome, that we continue to have almost half of the STS mortality every year. We continue to do this consistently despite the increasing complexity and volume. Unfortunately, last year we've had hyperacute rejection, a couple of transplants. However, we continue to improve the outcome, and the availability of organs is very difficult for congenital heart surgery. This is the outcome again that has dropped dramatically since 2015 and continue to be half of what it is. This is where we are in the STS mortality and our confidence level. So if we have a starting rate that has been deleted by the STS because of the sensitivities around the larger children's hospital programs. However, this is where we are. We clear actually the lower level. Our upper level clears the lower level of the STS. So if there was a starting rate, we would be a 3-star program. In U.S. News and World Report, again, we are one of 3 programs only that consistently in the last 3 years stayed in the best 10 programs in the country. Again, it's a very competitive field with the children's hospitals. In Newsweek, we are number 3. And if we look here again, the STS has stopped producing the overall outcome of the entire programs in the country, and the reason why they just have individual program transparencies. However, we pulled this manually. So these are a comparison of our program compared to the surrounding programs. This is our program, which we have the largest volume compared to the surrounding programs and the best outcome. So this is CS-MOT, Cincinnati, CHOP, Nationwide, Akron Children. This is the results 4 years tracking, and this is when they were in collaboration with us. I would expect that this is going to change soon, and Rainbow Children. And if you look at the 10 ranked hospitals in U.S. News and World Report, we are actually, again, one of the best outcomes in the best 10 compared to the other 8 before us. And if you look at the 50 hospitals, best ranked hospitals, again, we rank one of the best outcome. This is, you don't need a study to look at outcome volume versus mortality. You see the green dots are the mortalities and the volumes are, we're here sorted by volume. So the largest volume that we have in the last 4 years is Boston, and ours is number 8. However, we are the lowest mortality, as you would see, among the high volume centers. And if you look to the right, obviously there are some smaller programs which does few cases with lower mortality, but however, this is very selective cases. And again, this is sorted out by the highest volume centers. This is where we rank. And among the high volume centers, we still are the best outcome in those space. And hopefully next year with the next harvest, we're going to move to a second place with this. This is actually published data. Not only this, we continue to do our OTE ratio is one of the best also in the country. It's not actually larger volume only. And I think with the ACHD new risk adjustment models, we're going to be at least given some credit to what we do, because at this point we're still not getting enough credit for the complexity of the ACHD because of the module is still being developed soon. We've been known for innovative surgery all the last few years. We've developed the ventricular switch procedure, which has been born here at the clinic, and we've been known for this. This is one of the cases of a double aortic right ventricle with a VSD. We've been actually asked to publish an atlas for the biventricular conversion, whether it's a conversion of an LV-based Fontan or an RV-based Fontan, or RV-based biventricular conversion, which is the ventricular switch procedure that we've developed. This is in press, it's coming out. Each one of these will have at least 30 or 40 diagrams to show the rest of the surgeons how they can do these procedures. Everybody knows that we have actually developed also the transcolon unroofing of AOCA, which is a novel operation that has been developed here, and it's the only answer for these patients with a transseptal course of anomalous coronary. Another procedure for the distant pulmonary veins using a pericardial roll, and another novel procedure that actually saves these babies with pulmonary atresia intact septum with an RV-dependent coronary circulation, that they actually do not need a transplant. They can have a revascularization with an aortic to tricuspid valve that we've done actually 2 cases here so far and being very successful. And I think this is an answer for the rest of the world where they do not have neonatal heart transplantation. So this is how they, and obviously the fetal surgery has been. We have been continuing to also expand on our expandable heart valve, which is a valve that we have developed here at the clinic with this is as small as it is. This is an unmet need in newborns with needing an atrioventricular valve replacement. This starts at 8 millimeters, and we have a patent on that one. Basically, we can do either a homograft on that device or do a pulmonary autograft that can grow with the baby. So you do have an ability for this valve to grow. This is the animal testing. This is where we are on it. And this is how the valve beautifully works. Can I have this? Yeah, there it is. This is a camera inside the heart as it works. So this is with the pulmonary autograft mounted in that device. We still have to go through a few iterations of that to continue this is the last design of that, and hopefully this would be, it gets into the crimped position, and then it self-expands with time, and hopefully that will actually save the patient, the baby, repeated operation. We've been able to do also substantial conferences all through the years since we started, and we've been recognized not only nationally and internationally for all the novel operations that we have done. Thank you.